Back in the 1960s, a patient isolator unit was developed for cancer patients undergoing chemotherapy. Because their immune system cells were often caught in the friendly fire, up to 50% of cancer patients died of infections before they even completed the chemo, because their immune systems had become so compromised. So they developed this bubble boy-like contraption where they shave you, dip you in disinfectant, rinse you off with alcohol, antibiotic ointment in every orifice, and a rotating regimen of a dozen of the most powerful antibiotics we had. Procedures were performed through plastic sleeves, and everything in and out had to be sterilized and passed through airlocks, and so no fresh fruits and vegetables. People went crazy, cooped up in these things, with 38% of people starting to hallucinate. 15 years later, the results were in. It simply didn't work. People were dying at the same rate, so the whole thing was scrapped, except the diet. The airlocks and alcohol baths were banned, but they continued to make sure no one got to eat a salad. Neutrophils are our front line of defense white blood cells, and so when we're immunocompromised, when we don't have enough neutrophils, we're called neutropenic, so patients are put on a neutropenic diet, no fresh fruits and vegetables. The only thing is that there's a striking lack of evidence that such a diet actually helps. Ironically, the neutropenic diet is the one component that's still practiced, yet has the least evidence supporting its use. The rationale was like, look, there's bacteria on salad, bacteria cause infections, and so look, immunocompromised patients are at increased risk of infections, so no salad for you. And frankly, we're glad there's no studies on it, because it could be way too risky to give a cancer patient a salad. So its continued use seemed to be based on this kind of better safe than sorry philosophy. OK, but the problem is, look, kids diagnosed with cancer come in already low in dietary antioxidants. The last thing you'd think you'd want to say is no fresh fruit. So in addition to the lack of clinical evidence for this diet, there may be some drawbacks. Maybe restriction of fruits and vegetables may increase the risk of infection, compromise the nutritional status. So are neutropenic diets for cancer patients reasonable prudence or clinical superstition? A resurgence of research started during the 90s, when the need to support clinical practice with, wait for it, evidence became increasingly important. What a concept! In other words, you don't know until you put it to the test. 3 randomized controlled trials were published, and none supported the neutropenic diet. This was the biggest, an all-cooked diet versus one that allowed raw fruits and vegetables, and there was no difference in infection and death rates. As a result of the study, the principal investigator at the MD Anderson Cancer Center described how their practice has changed, and now everyone is allowed to eat their vegetables, a far cry from the "please don't eat the salads" 31 years earlier. Today, neither the FDA nor the CDC support the neutropenic diet, nor does the American Cancer Society. The real danger are the pathogenic food poisoning bacteria, Campylobacter, Salmonella, E. coli, so you still have to keep people away from risky foods like undercooked eggs, meat, dairy, and sprouts. At this point, there really shouldn't even be a debate, though. Yet many institutions continue to tell cancer patients they shouldn't eat fresh fruits and veggies. According to the latest survey, more than half of pediatric cancer doctors continue to prescribe these diets, though it's quite variable even among those at the same institution. Why are doctors still reluctant to move away from the neutropenic diet? Well, there's several reasons why doctors may be hesitant to incorporate evidence-based medicine into their practice. They have limited time to review the literature. They'd like to dig deep into studies, but they simply don't have the time to look at the evidence. That's what nutritionfacts.org is for. Bone marrow transplants are the final frontier. Sometimes it's our immune system itself that is cancerous, leukemia, lymphoma. And so the immune system is wiped out on purpose to rebuild from scratch, and so inherent in the procedure is a profound immunodeficiency, for which a neutropenic diet is often recommended, but had never been tested until now. Not only did it not work, a strict neutropenic diet was actually associated with an increased risk for infection. Maybe because you didn't have all the good bugs from fruits and veggies crowding out the bad guys in the gut? Not only was the neutropenic diet not beneficial, but there was a suggestion that it could be potentially harmful. It would not be the first time that an intervention strategy made good theoretical sense, but ultimately was ineffective when put to the test. It is commonly thought that those who eat plant-based diets may be more prone to iron deficiency, but it turns out they're no more likely to suffer from iron deficiency anemia than anybody else. This may be because not only do those eating meat-free diets tend to get more fiber, magnesium, vitamins A, C, and E, but also get more iron. But the iron found in plants is non-heme iron. Those eating meat-free diets don't get much of the heme iron found in blood and muscle, which may be a good thing. The avoidance of heme iron may be one of the key elements of plant-based protection against metabolic syndrome, may also be beneficial in lowering heart disease risk. The link between iron intake and coronary heart disease has been contentiously debated, but the inconsistency of the evidence may be because the majority of total dietary iron comes mostly from plants, and so total iron intake is associated with lower heart disease risk. But if you just look at iron intake from meat, it's associated with significantly higher risk for heart disease. This is thought to be because iron can act as a pro-oxidant, contributing to the development of atherosclerosis by oxidizing cholesterol with free radicals. The risk has been quantified as a 27% increase in coronary heart disease risk for every 1 milligram of heme iron consumed daily. The same has been found for stroke risk. The studies on iron intake and stroke had conflicting results, but maybe because they'd never separated out heme from non-heme iron until this study, which found that the intake of meat iron, but not plant iron, was associated with increased risk of stroke as well as diabetes. Higher animal iron intake significantly associated with greater risk of type 2 diabetes, but not total or plant iron. 16% increase in risk for every daily milligram of heme iron consumed, and the same for cancer, with up to 12% increased risk for every milligram of daily heme iron exposure. In fact, you can actually tell how much meat someone is eating by looking at their tumors. To characterize the mechanisms underlying meat-related lung cancer development, they asked lung cancer patients how much meat they ate, and examined the gene expression patterns in their tumors, and identified a signature pattern of heme-related gene expression. Though they just looked at the lung cancer, they expect these meat-related gene expression changes may occur in other cancers as well. We do need to get enough iron, but only about 3% of premenopausal white women have iron deficiency anemia these days. However, the rates are worse for African and Mexican Americans. Taking our leading killers into account, heart disease, cancer, diabetes, the healthiest source of iron, it appears to be non-heme iron, found naturally in abundance in whole grains, beans, split peas, chickpeas, and lentils, dark green leafy vegetables, dried fruits, and nuts and seeds. But how much money can be made on beans? So the industry came up with a blood-based crisp bread made out of rye and cattle and pig blood, one of the most concentrated sources of heme iron, about 2/3 more than chicken blood. Now, if blood-based crackers don't sound particularly appetizing, no worries. There's also cow blood cookies and blood-filled biscuits. The filling ends up a dark-colored, chocolate-flavored paste with a very pleasant taste, dark-colored because spray-dried pig blood can have a darkening effect on the food product's color. But the worry is not the color or taste, it's the heme iron, which, because of its potential cancer risk, is not considered safe to add to foods intended for the general population. There was a report recently of a woman in San Francisco suffering from nathostomiasis. I learned about it in med school and never actually saw a case, though evidently it's now on the rise. Clinically, the disease commonly presents as migratory cutaneous swellings, bumps on the skin that move around. Why? Because there's a worm under there. They migrate through the subcutaneous tissues under the skin and cause migratory episodes, recurrent episodes of migratory swelling or creeping eruptions. There's no effective treatment, really, other than removal of the worm. Here's a picture of the thing. Note its head has these rings of little hooks that allow it to burrow through tissue. Because humans are essentially a dead-end host for the larva, no further development in mature worms can occur, and symptoms are experienced owing to the wandering of the organisms throughout the body. It can also crawl into our eyeballs. A 42-year-old woman with a 4-year history of migratory swellings on her face, then a little bleeding from the eyelid. You know where this is going. No problem, though. You can make a little cut, stick some forceps in, locate the worm, and then just pull the puppy out of the eyeball. But if you have any pimples on your face that move around, better to grab them before they start swimming around in your eyes. By far the most serious manifestation, though, is when they get into your brain. As the worm migrates along the nerves, the patient can experience excruciating pain. It can lead to paralysis, bleeding in the brain, and finally death. But in non-cerebral diseases, the worms that die, though it may take about 12 years. How do the worms get into our brain, though? So-called neuronathostomiosis. These nathostoma worms are highly invasive parasites. After leaving the sushi bar, the larvae penetrate the wall of the intestine. They can then enter the brain through the base of the skull, crawling along the spinal nerves and vessels. They start out in the nerve roots, enter the spinal cord, and then can climb up into our brain. The worm isn't poisonous or anything. It's just a migration of the worm through the body that causes direct mechanical injury just because of the tearing of the nerve tissue. Bottom line, this diagnosis should be considered in patients who present with nonspecific little lumps and bumps, especially when there's a history of frequent consumption of raw fish. Thankfully, most raw foodists stick to plants and thereby avoid things like this. 21-year-old woman experiences acute, severe pain in her mouth immediately after swallowing a raw squid. Seems consumption of a squid with sperm bags and the active ejaculatory apparatus can lead to unintended ejection of the sperm bag and injury to the oral cavity. The habit of eating raw food, especially living organisms, is risky. Though some living organisms, plants, are substantially less risky than others. Many successful herbal treatments start like this. Some doctor learns that some plant has been used by some ancient medical tradition, like ginger for headaches, and figures, hey, they've got patients with headaches, and since it's just some safe, common spice, advises one of their migraine patients to give it a try. At the first sign of a migraine coming on, the patient mixed a 1/4 teaspoon of powdered ginger and some water, drank it down, and poof! Within a half hour, the migraine went away. And it worked every time, no side effects. This is what's called a case report, which is really just a glorified anecdote, but case reports have played an important role in the history of medicine. AIDS was first discovered as a series of case reports. Some young guy walks into a clinic in Los Angeles with a bad case of thrush, and the rest is history. Or reports of an unusual side effect of a failed chest pain drug leading to the billion-dollar blockbuster Viagra. Case reports may be the lowest or weakest form of evidence, but they're often the first line of evidence. That's where everything begins. So a report like this isn't helpful in and of itself, but it can inspire researchers to put it to the test. The problem is, who's going to fund it? The market for migraine drugs is worth billions of dollars. A 1/4 teaspoon of powdered ginger costs about a penny. So who'd fund a study pitting ginger versus the leading migraine drug? No one. Until now. A double-blinded, randomized, controlled clinical trial comparing the efficacy of ginger to sumatriptan, also known as Imitrex, one of the top-selling billion-dollar drugs in the world, in the treatment of migraine headaches. They tried using just 1/8 of a teaspoon of powdered ginger versus a good dose of the drug, and they both worked just as well, just as fast. Most started out in moderate or severe pain before, but after the drug or ginger ended up mild or pain-free. The same proportion of migraine sufferers reported satisfaction with the results either way, and so as far as I'm concerned, ginger won. Not only because it's a few $1 billion cheaper, but because there were significantly fewer side effects in the ginger group. On the drug, people reported dizziness, a sedative effect, vertigo, and heartburn. The only thing reported for ginger was an upset tummy in about 1 in 25 people, though taking a whole tablespoon of ginger powder at one time on an empty stomach could irritate anyone's tummy, just as a note of caution. But sticking to an eighth of a teaspoon is not only up to 3,000 times cheaper than the drug, but you're probably less likely to end up as a case report yourself of people that have had a heart attack or died after taking the drug. Studies suggest that excessive animal protein consumption poses a risk of kidney stone formation, likely due to the acid load provided by the high content of sulfur-containing amino acids in animal protein, as I explored in my video on preventing kidney stones with diet. But what about treating kidney stones? Most stones are calcium oxalate, formed like rock candy when the urine becomes supersaturated. So doctors just assumed if they're made out of calcium, we just have to tell people to reduce their calcium intake. So that was like the dietary gospel for kidney stone sufferers, until this study was published in the New England Journal of Medicine, pitting the two diets against one another, low calcium versus low animal protein and salt, and it was the restriction of animal protein and salt that provided greater protection, cutting the risk of having another kidney stone within 5 years in half. What about cutting down on oxalates, which are concentrated in certain vegetables? A recent study found that there was no increased risk of stone formation with higher vegetable intake. In fact, greater dietary intake of whole plant foods, fruits and vegetables, were each associated with a reduced risk independent of other known risk factors for kidney stones, meaning one may get additional benefits bulking up on plant foods in addition to just restricting animal foods. The reasons a reduction in animal protein helps is not only because it reduces the production of acids within the body. A reduction of animal protein should also limit the excretion of urate, uric acid crystals, that can act as a seed to form calcium stones, or it can create entire stones themselves. Uric acid stones are the second most common kidney stones after calcium. There's two ways to reduce uric acid levels in the urine: a reduction in animal protein ingestion, or drugs. And removing all meat can remove 93% of uric acid crystallization risk. Here's the risk of crystals forming eating the standard Western diet for 5 days, and then switching to a vegetarian diet. Leads to a 93% drop in risk within days. To minimize uric acid crystallization, the goal is to get the urine pH up to ideally as high as 6.8, so a number of alkalizing chemicals have been developed. We can naturally alkalize our urine up to the recommended 6.8 using purely dietary means, namely by removing all meat, which takes someone eating the standard Western diet up from an acid 5.95 right up to the target of 6.8 eating a vegetarian diet. You can inexpensively test your own diet with a little bathroom chemistry, for not all plant foods are alkalizing, and not all animal foods are equally acidifying. A so-called Lake score was developed, a load of acid to kidney score, which takes into account both the acid load of foods and their typical serving sizes, and can be used to help people modify their diet for the prevention of both uric acid and calcium kidney stones and other diseases. This is what they found. The single most acid-producing food was fish, like tuna, then pork, then poultry, then cheese, though milk and other dairy only rates down here. Then comes beef. Now, eggs are actually more acidic than beef, more acid-forming, but people tend to eat less eggs at a sitting, so they come in here. Some grains can be a little acid-forming, such as bread, rice, but not pasta, interestingly. Beans are significantly alkaline-forming. but not as much as fruits. And vegetables are the most alkaline-forming of all foods. Through dietary changes alone, we may be able to dissolve uric acid stones away completely, cure them. Now you see it, now you don't. No drugs, no surgery, just telling them to drink more water and modify their diet, such as restricting the intake of animal protein, and the kidney stone was gone. To summarize, here are the 5 types of kidney stones, and the most important things we can do diet-wise is to drink 10 to 12 cups of water a day, and reduce animal protein, reduce salt, eat more vegetables, and more vegetarian. Colorectal cancer is the second leading cause of cancer death in the United States, after lung cancer. If you look at the rates of lung cancer around the world, they vary by a factor of 10. If there was nothing we could do to prevent lung cancer, if it just arose spontaneously, happened at random, you'd assume that the rates everywhere would be the same. But since there's such a huge variation in rates, you assume there's some external cause. And indeed, we now know smoking is responsible for 90% of lung cancer cases. So if we don't want to die of the #1 cancer killer by just not smoking, we can throw 90% of our risk out the window. For colon cancer, there's an even bigger spread, bigger variation around the world. So it appears colon cancer doesn't just happen, something makes it happen. Well, if our lungs can get filled with carcinogens from smoke, maybe our colons are getting filled with carcinogens from food. Researchers from the University of Pittsburgh and the University of Limpopo sought to answer the question, why do African Americans get more colon cancer than native Africans? Why study Africans? Because colon cancer is extremely rare in native African populations, like more than 50 times lower than rates of Americans, white or black. It's the fiber, right? Dr. Burkitt was the first to describe the low incidence of colon cancer in native Africans, ascribing it to their traditional staple diet that was high in whole grains and therefore fiber content. Seems you get about a 10% reduction in risk for every 10 grams of fiber a day, so hey, if it's 1% drop for each gram, and they're eating upwards of 100 grams a day, well, that could explain why colon cancer is so rare in sub-Saharan Africa. But wait a second. The modern African diet is highly processed, low in fiber, and yet there's been no dramatic increase in colon cancer incidence. The modern African diet has a low fiber content, as most populations now depend on commercially produced refined cornmeal. We're not just talking low fiber intake, we're talking United States of America low, down around half the recommended daily allowance. Yet colon disease still remains rare, still 50 times less colon cancer. Maybe it's because they're thinner and exercise more? No, they're not, and no, they don't. If anything, their physical activity levels may now be even lower. So if they're sedentary like us, eating mostly refined carbs, few whole plant foods, little fiber like us, why do they still have 50 times less colon cancer than us? Well, there is one difference. The diet of both African Americans and Caucasian Americans is rich in meat, whereas the native Africans' diet is so low in meat and saturated fat, they have total cholesterol levels averaging 139, compared to over 200 in the US. So yes, they don't get a lot of fiber anymore, but they continue to minimize meat and animal fat consumption, supporting evidence that perhaps the most powerful determinants of colon cancer risk are the levels of meat and animal fat intake. So why do Americans get more colon cancer than Africans? Maybe the rarity of colon cancer in Africans is not the fiber, but their low animal product consumption. There's a divergence of opinion as to whether it's the animal fat, cholesterol, or animal protein that's most responsible for the increased cancer risk, as all three have been shown to have carcinogenic, cancer-causing properties. But it may not really matter which component is worse, as a diet rich in one is usually rich in the others. High blood pressure ranks as the #1 risk factor for death and disability in the world. Previously, I showed how a plant-based diet may prevent high blood pressure, but what if you already have it? The American Heart Association, American College of Cardiology, and the Centers for Disease Control and Prevention recommend as the first-line treatment lifestyle modification. If that doesn't work, you can start the patient on a thiazide diuretic or water pill, and then you keep piling on the meds until you get their blood pressure down. Commonly, people end up on 3 drugs, though researchers are experimenting with 4 at a time, and some people end up on 5. Why not just jump straight to the drugs? Well, they don't treat the underlying cause, and they can cause side effects. Less than half of patients stick with even the first-line drugs, perhaps due to the adverse effects such as erectile dysfunction, fatigue, and muscle cramps. So, what are these recommended lifestyle changes? They recommend to control one's weight, salt, and alcohol intake, engage in regular exercise, and adopt a DASH eating plan. The DASH diet has been described as a lacto-vegetarian diet, but it's not. It emphasizes fruits and vegetables and low-fat dairy, but just a reduction in meat. Why not vegetarian? We've known for decades that food of animal origin is highly significantly associated with blood pressure. In fact, if you take vegetarians and you give them meat, you can watch their blood pressures go right up. I've talked about how there are benefits to getting blood pressure down as low as 110/70, but who can get that low? Populations eating plant-based diets, like in rural China, about 110/70 their whole lives, with meat only eaten special occasions, or rural Africa, where the elderly have perfect blood pressure as opposed to hypertension. In the Western world, as the American Heart Association has pointed out, the only folks really getting down that low were the strict vegetarians, coming out at about 110/65. So when they created the DASH diet, were they just not aware of this landmark research done by Harvard's Frank Sachs? No, they were aware. The chair of the design committee that came up with the DASH diet was Dr. Sachs. In fact, the DASH diet was explicitly designed with the #1 goal of capturing the blood pressure-lowering benefits of a vegetarian diet, yet contain enough animal products to make it palatable to the general public. In fact, Sachs found that the more dairy the lacto-vegetarians ate, the higher their blood pressures. But they had to make the diet acceptable. Research has since shown that it's the added plant foods, not the changes in oil, sweets, or dairy, that appears to be the critical component, so why not eat plant-based? Recent meta-analysis showed vegetarian diets were good, but strictly plant-based diets may be better. Vegetarian diets in general confer protection against cardiovascular disease, some cancers, and death, but completely plant-based diets seem to offer additional protection for obesity, hypertension, type 2 diabetes, and heart disease mortality. Based on a study of 89,000 people, those eating meat-free diets appeared to cut their risk of high blood pressure 55%, but those eating meat-free, egg-free, and dairy-free had 75% lower risk. If, however, you're already eating a whole food plant-based diet, no processed foods, no table salt, and you're still not hitting 110/70, there are a few foods recently found to offer additional protection. Ground flax seeds, a few tablespoons a day, induce one of the most potent antihypertensive effects ever achieved by a dietary intervention, 2 to 3 times more powerful than instituting an aerobic endurance exercise program. Watermelon also appears to have extraordinary effects, but you'd have to eat like 2 pounds a day. Sounds like my kind of medicine, but it's hard to get year-round. Red wine may help, but only if the alcohol has been taken out. raw vegetables, or cooked? And the answer is both, though raw may work better. Beans, split peas, chickpeas, and lentils may help a little. Kiwi fruits, though, don't seem to work at all, even though the study was funded by a kiwi fruit company. Maybe they should have taken direction from the California Raisin Marketing Board, who came out with this study showing raisins can reduce blood pressure, but only, apparently, compared to fudge cookies, Cheez-Its, and Chips Ahoy. We've been playing music since back during the Paleolithic era, 40,000 years ago, with music as therapy documented at least since biblical times. The first such experiment was published in the Journal of the American Medical Association in 1914, Phonograph in Operating Room, as a means of calming and distracting patients from the horror of the situation as they lie awake during surgery. Now that we have anesthesia, music is used to calm nerves before surgery. Normally we use Valium-type drugs like midazolam, sold as Versed, but it can have a variety of side effects, including sometimes making people even more agitated. So this study was performed to see if relaxing music has a greater anxiety-reducing effect than a standard dose of the drug. So they whipped out some Kenny G, and the music worked significantly better than the drug. Lower anxiety scores, lower heart rate, lower blood pressure. Perhaps the first report of any anti-anxiety therapy working not just as good as, but better than benzodiazepine drugs. And the difference in the side effects of relaxing music compared to the drug is obvious. Right? There were none. Soft jazz causes no post-operative hangover. So the researchers suggest we should start using music instead of midazolam. Music may be effective in reducing anxiety and pain in children as well, undergoing minor medical and dental procedures, helping with blood draws, getting their shots, even reducing the pain of spinal taps, though evidently Mozart is powerless against the pain of circumcision. But it doesn't take a randomized controlled trial to demonstrate that listening to music can be relaxing. Tell me something I don't know. OK, this I did not know. If you take someone with a latex allergy and inject their skin with latex, they get a big red angry bump. Right? But if you repeat the test after they've been listening to Mozart for 30 minutes, they develop a much smaller bump. They had less of an allergic reaction. And if you think that's wild, Beethoven didn't work. Same reaction kind of before and after. Right? So it wasn't just the music. Schubert didn't work either, nor did Haydn or Brahms. Both failed to reduce the allergic skin response. Thus, the reducing effect on the allergic responses may be specific to Mozart. So Mozart's looking pretty good, but wait a second, maybe Mozart suppresses the immune system in general. That wouldn't be good. So they also injected a chemical that causes reactions in everyone, not just allergic people, and Mozart had no effect. So it seems to just suppress the pathological allergic reaction. And if that isn't crazy enough for you, they drew people's blood after the music and stuck their white blood cells in a petri dish with a little latex and measured the allergic antibody response. The white blood cells from the person exposed to Mozart had less of an allergic response even outside the body compared to cells taken from Beethoven blood. That is cool. Music may even impact our metabolism. It all started with this study. They found that the resting energy expenditure, the resting metabolic rate, the amount of calories burned just lying around, was lower in preemies when they piped in Mozart, which may explain why infants exposed to music put on weight faster, so much so they were able to go home earlier. Now, gaining weight faster is great for premature babies, but not necessarily for adults. Could listening to music slow our metabolism and contribute to weight gain? No. This study found no effect on adults, but they used Bach, not Mozart, and Bach doesn't work for babies either. A drop in energy expenditure on Mozart, but not on Bach. This would suggest that it may be more of a Mozart-specific effect than a universal music effect. What if you just listen to music of your choice? Does it affect our metabolism or not? We didn't know until now. And it turns out that listening to music appears to actually increase our metabolic rate, such that we burn an average of 27.6 more calories a day, even just lying in bed, though that's only about 6 M&Ms worth. Better to use music to get up and start dancing or exercising. Music can not only improve exercise enjoyment, but performance as well. A way to improve athletic performance that's legal. Male bodybuilders may be less enthused by this effect, though. After listening to music for just 30 minutes, testosterone levels drop 14% in young men and go up 21% in young women. All kinds of music, or just some types of music. 30 minutes of silence had no effect, same testosterone levels before and after, but a half an hour of Mozart suppressed testosterone, as did jazz, as did pop music, as did Gregorian chants, no relation. What about a half hour of people's personal favorites? Testosterone levels cut in half. Testosterone decreased in males under all music conditions, whereas testosterone increased in the females. What is going on? Well, in men, testosterone is related to libido, dominance, aggressiveness, whereas women get a bigger boost in testosterone from cuddling than from sex. And so maybe we evolved using music as a way to ensure we all got along, like a melodious cold shower to keep everyone kind of chilled out. In terms of preventing acid reflux heartburn, I've talked about how high-fat meals cause dramatically more acid exposure in the esophagus in the hours after a meal. But why does high fiber intake decrease the risk? One typically thinks of fiber helping out much lower in the digestive tract. A systematic review and meta-analysis found a highly significant protective association between esophageal adenocarcinoma and dietary fiber intake, suggesting that individuals with the highest fiber intakes have approximately 30% lower risk of cancer. This could be because of the phytates in high-fiber foods slowing cancer growth, could be the anti-inflammatory effects, fiber could be removing carcinogens, but those are all generic anti-cancer effects of whole plant foods. Specific to this type of acid irritation-induced esophageal cancer, fiber may decrease the risk of reflux in the first place. But how? Hiatus hernia occurs when part of the stomach is pushed up through the diaphragm into the chest cavity, which makes it easy for acid to reflux up into the esophagus and throat. It affects more than 1 in 5 American adults. In contrast, in rural African communities that were eating their traditional plant-based diets, it wasn't 1 in 5, it was closer to 1 in 1,000, almost unheard of. It's almost peculiar to those who consume Western-type diets. Why are plant-based populations protected? Perhaps because they pass such large, soft stools, 3 or 4 times the volume as Westerners. What does the size and consistency of one's bowel movement have to do with hiatal hernia? A simple model may help illustrate the mechanism producing upward herniation of the stomach through the hole in the diaphragm that separates the abdomen from the chest, called the esophageal hiatus. That's the opening. If a ball with a hole in it is filled with water and then squeezed, the water is pushed out through the hole. The abdominal cavity may be likened to a ball, the hole in the ball corresponding to that esophageal hiatus in the diaphragm. So abdominal straining during efforts to evacuate firm feces corresponds to squeezing the ball, and may result in gradual expulsion of the upper end of the stomach from the abdominal cavity up into the chest. It's like when you squeeze one of those stress balls. Straining at stool raises pressures inside our abdominal cavity more than almost any other factor. When we bear down and strain at stool, it's like squeezing our abdomen and may herniate part of our stomach up. Consistent with this concept is the observation that in Africans, the lower esophageal sphincter is entirely subdiaphragmatic, whereas it usually straddles the diaphragm in Westerners, and is above the diaphragm in the presence of hiatus hernia. And the same abdominal pressure from straining that may cause hiatal hernias may cause a number of other problems. The straining can cause herniations in the wall of the colon itself, known as diverticulosis. And the same pressure can also back up blood flow into the veins around the anus, causing hemorrhoids, and push blood flow back into the legs, resulting in varicose veins as well. Weight loss surgery for children and adolescents is becoming widespread, performed in children as young as 5 years old. Roux-en-Y gastric bypass is the most common type of procedure in which they cut out nearly the entire stomach. Yes, bariatric surgery in pediatric patients results in weight loss, but also has the potential for serious complications, including pulmonary embolism, shock, intestinal obstruction, postoperative bleeding, leaking along the staple line, and severe malnutrition. Complications include death, a mortality rate of 0.5%. That would mean 1 in 200 kids that go under the knife may die. Infection is identified as the leading cause of death, most often associated with leaking of intestinal contents into the abdominal cavity. Sometimes it doesn't work, and you have to go in and do another procedure, and if that doesn't work, we can always try implanting electrodes into their brains, a novel anti-obesity strategy recently reported in the Journal of Neurosurgery. The concept of a deep brain stimulation has always been that placing an electrode somewhere in the brain could make people eat less. They just drill 2 little holes in your skull, snake some electrodes in a few inches, and then tunnel the wires under your scalp into a pulse generator you implant under the skin on your chest. You can't crank it up past 5 volts because it induces anxiety and nausea, but even without the nausea, people with electrodes stuck in their brains lost an average of about 10 pounds a year. After about age 20, we may have all of the insulin-producing beta cells we're ever going to have in our pancreas, and so if we lose them, we may lose them for good. Autopsy studies show that by the time type 2 diabetes is diagnosed, we may have already killed off half of our beta cells. You can do it right in a petri dish. Expose human beta cells to fat, they suck it up, and then start dying off. A chronic increase in blood fat levels is harmful, as shown by the important effects in pancreatic beta cell lipotoxicity. Fat breakdown products can interfere with the function of these cells and ultimately lead to their death. And not just any fat, saturated fat. The predominant fat in olives, nuts, and avocados gives you a tiny bump in death protein 5, but saturated fat really ramps up this contributor to beta cell death. Saturated fats are harmful to beta cells, harmful to the insulin-producing cells in our pancreas. Cholesterol, too. The uptake of bad cholesterol, LDL, can cause beta cell death as a result of free radical formation. So, diets rich in saturated fats not only cause obesity and insulin resistance, but the increased levels of circulating free fats in the blood, called NEFAs, non-esterified fatty acids, causes beta cell death, and may thus contribute to progressive beta cell loss in type 2 diabetes. And this isn't just based on test tube studies. If you infuse fat into people's bloodstream, you can directly impair pancreatic beta cell function, and the same when we ingest it. Type 2 diabetes is characterized by defects in both insulin secretion and insulin action, and saturated fat appears to impair both. Researchers showed saturated fat ingestion reduces insulin sensitivity within hours, but these were non-diabetics, so their pancreas should have been able to boost insulin secretion to match, but insulin secretion failed to compensate for insulin resistance in subjects who ingested the saturated fat, and this implies that saturated fat impaired beta cell function as well, again just within hours after going into our mouth. So, increased consumption of saturated fats has a powerful short and long-term effect on insulin action, contributing to the dysfunction and death of pancreatic beta cells in diabetes. And saturated fat isn't just toxic to the pancreas. The fats found predominantly in meat and dairy, chicken and cheese are the two main sources in the American diet, are almost universally toxic, whereas the fats found in olive nuts and avocados are not. Saturated fat has been found to be particularly toxic to liver cells in the formation of fatty liver disease. You expose human liver cells to plant fat, and nothing happens. Expose liver cells to animal fat, and a third of them die. This may explain why higher intakes of saturated fat and cholesterol are associated with non-alcoholic fatty liver disease. By cutting down on saturated fat consumption, we may be able to help interrupt this process. Decreasing saturated fat intake may help bring down the need for all that excess insulin. So either being fat or eating saturated fat can both cause that excess insulin in the blood. The effect of reducing dietary saturated fat intake on insulin levels is substantial, regardless of how much belly fat we have. And it's not just that by eating fat we may be more likely to store it as fat. Saturated fats, independently of any role they have of making us fat, may contribute to the development of insulin resistance and all its clinical consequences. After controlling for weight and alcohol and smoking and exercise and family history, diabetes incidence was significantly associated with the proportion of saturated fat in our blood. So what causes diabetes? The consumption of too many calories rich in saturated fats. Now, just like everyone who smokes doesn't develop lung cancer, everyone that eats a lot of saturated fat doesn't develop diabetes. There's a genetic component. But just like smoking can be said to cause lung cancer, high-calorie diets rich in saturated fats is currently considered the cause of type 2 diabetes. The World Health Organization recommends we reduce our consumption of salt, trans fats, saturated fats, and added sugars. Why? Because consumption of such foods is the cause of at least 14 million deaths every year from chronic diseases. Several decades ago, it was heresy to talk about the impending global pandemic of obesity, but now we're seeing chronic disease rates skyrocket around the world. We have exported our Western diet to the far reaches of the planet, with white flour, sugar, fat, and animal-sourced foods replacing beans, peas, lentils, other vegetables, and whole grains. Understanding the reasons underlying this trend towards increased consumption of animal products, oils, and sugar, and the reduced consumption of whole plant foods begins with understanding the purposeful economic manipulations that have occurred since World War II relating to agricultural policies around the world. For example, the U.S. government, since early in the last century, has supported food production through subsidies and other policies, resulting in large surpluses of food commodities, meat, and calories. In this artificial market, large food producers and corporations, Big Ag and Big Food, became very profitable, and that may be part of the problem. Last year, Dr. Margaret Chan, the Director General of the World Health Organization, gave the opening address at a global conference on health promotion. One of the biggest challenges facing health promotion worldwide, she said, is that the efforts to prevent our top killers go against the business interests of powerful economic operators. It's not just big tobacco anymore. Public health must also contend with big food, big soda, big alcohol. All of these industries fear regulation and protect themselves by using the same tactics: front groups, lobbies, promises of self-regulation, lawsuits, and industry-funded research that confuses the evidence and keeps the public in doubt. And they should know. In 2003, the World Health Organization released a draft report outlining a global strategy to address issues of diet, making a series of rather tame recommendations. But 6 words in that report: limit the intake of free sugars, stimulated a remarkable series of events. Free sugars means added sugars. The food industry went to work. Within days, the sugar industry, through the Sugar Association, enlisted the support of officials high in the U.S. government and led a vigorous attack on both the report and the World Health Organization itself, culminating in a threat to get Congress to withdraw U.S. funding to the WHO. The organization that deals with AIDS, malnutrition, infectious disease, bioterrorism, and more, threatened because of its stance on sugar. Just as the U.S. went to bat for U.S. tobacco companies and led the charge against World Health Organization's Framework Convention on Tobacco Control. But the threat from the sugar industry was described by WHO insiders as worse than any pressure they ever got from the tobacco lobby. As revealed in an internal memo, the U.S. government apparently had a list of demands, deletion of all references to the science that experts compile on the matter, and having dietary guidelines are fine as long as there are no references to fat, oil, sugar, or salt. The threats failed to make the WHO withdraw their report. Entitled Diet, Nutrition, and the Prevention of Chronic Diseases, it formally launched and concluded that a diet low in saturated fat, sugar, and salt, and high in fruit and vegetables was required to tackle the epidemic rise in chronic diseases worldwide, though they did end up watering it down. GONE was referenced to the Comprehensive Scientific Report, and GONE was its call for recommendations to actually be translated into national guidelines. History has since repeated. At the last high-level UN meeting to address chronic diseases, we helped block a consensus on action after lobbying from the alcohol, food, tobacco, and drug industries. When asked why Michelle Obama's successful childhood obesity programs in the U.S. should not be modeled around the world, a U.S. official responded that they might harm American exports. Even though the most widely accepted, well-established chronic disease practice guidelines uniformly call for lifestyle change as the first line of therapy, physicians often do not follow these guidelines. Yet lifestyle interventions are often more effective in reducing heart disease, hypertension, heart failure, stroke, cancer, diabetes, and deaths from all causes than almost any other medical intervention. Some useful lessons may come from the war on tobacco, Dr. Neil Barnard wrote in the American Medical Association's Journal of Ethics. When he stopped smoking himself in the 80s, the lung cancer death rate was peaking in the U.S., but has since dropped with dropping smoking rates. No longer were doctors telling patients to give their throat a vacation by smoking a fresh cigarette. Doctors realized they were more effective at counseling patients to quit smoking if they no longer had tobacco stains on their own fingers. In other words, doctors went from being bystanders or even enablers to leading the fight against smoking. And today, he says, plant-based diets are the nutritional equivalent of quitting smoking. If we were to gather the world's top unbiased nutrition scientists and experts, there would be very little debate about the essential properties of good nutrition. Unfortunately, most doctors are nutritionally illiterate, and worse, they don't know how to use the most powerful medicine available to them, food. Physician advice matters. When doctors told patients to improve their diets, which was defined as cutting down on meat, dairy, and fried foods, patients were more likely to make dietary changes when their doctors advised them. And it may work even better if doctors practice what they preach. Researchers at Emory randomized patients to watch one of two videos. In one video, a physician briefly explained her personal healthy dietary and exercise practices and had a bike helmet and an apple visible on her desk. In the other, she did not discuss her personal practices, and the apple and bike helmet were missing. For example, in both videos, the doctor advised patients to cut down on meat, to not usually have meat for breakfast, and have no meats for lunch and dinner at least half the time as a kind of simple place to start improving their diets. But in the disclosure video, the physician related that she had successfully cut down on meat herself, and perhaps not surprisingly, patients rate that physician to be more believable and motivating. So physicians who walk the walk, literally, And have healthier eating habits may not only tend to counsel more about diet and exercise, but also appear more credible and motivating than when they do so. It may even make them better doctors. A randomized controlled interventional trial to clean up doctors' diets, called Promoting Health by Self-Experience, found that healthcare providers' personal lifestyles were directly correlated with their clinical performance. Healthcare providers' own improved well-being and lifestyle cascaded to the patients and clinics, suggesting an additional strategy to achieve successful health promotion. Are you ready for the best-kept secret in medicine? The best-kept secret in medicine is that, given the right conditions, the body heals itself. Treating cardiovascular disease, for example, with appropriate dietary changes is good medicine, reducing mortality without any adverse effects. Yes, we should keep doing research, but educating physicians and patients alike about the existing knowledge about the power of nutrition as medicine may be the best investment we can make. Ancient Egypt was one of the great civilizations lasting for 3,000 years, its knowledge of medicine vastly underestimated. They had medical subspecialties. The pharaohs, for example, had access to dedicated physicians to be guardians of the royal bowel movement, a title alternately translated from the hieroglyphics to mean shepherd of the anus. How's that for a resume builder? Today, the primacy of its importance continues, with some calling for bowel habits to be considered a vital sign on how the body is functioning, along with blood pressure, heart, breathing rate. Although we may not particularly like hearing the details of someone else's bowel movement, it is a function that nurses and doctors need to assess. Surprisingly, the colon remained relatively unexplored territory, one of the body's final frontiers. For example, current concepts of what normal stools are like primarily emanates from the detailed records of 12 consecutive bowel movements in 27 healthy subjects from the United Kingdom, who boldly went where no one had gone before. Those must have been really detailed records. The reason we need to define normal when it comes to bowel movement frequency, for example, is how else can you define concepts like constipation or diarrhea if you don't know what normal is? Standard physiology textbooks may not be helpful in this regard, implying that anything from one bowel movement every few weeks or months to 24 a day can be regarded as normal. Once every few months? Of all human bodily functions, defecation is perhaps the least understood and least studied. Can't you just ask people? Turns out people tend to exaggerate. There's a discrepancy between what people report and what researchers find when they actually have them recorded. It wasn't until 2010 when we got the first serious look, defining normal stool frequency as between 3 per week and 3 per day, based on the fact that that's where 98% of people tend to fall. But normal doesn't necessarily mean optimal. Having a normal salt intake can lead to a normal blood pressure, which can help us die from all the normal causes, like heart attacks and strokes. Having a normal cholesterol level in a society where it's normal to drop dead of heart disease, our #1 killer, not necessarily a good thing. And indeed, significant proportions of people with quote-unquote normal bowel function reported urgency, straining, incomplete defecation, leading the researchers to conclude that that kind of thing must just be normal. Normal, maybe, if you're eating a fiber-deficient diet, but not normal for our species. Defecation should not be a painful exercise. This is readily demonstrable. For example, the majority of rural Africans eating their traditional fiber-rich plant-based diets can usually pass without straining a stool specimen on demand. See, the rectum may need to accumulate 4 or 5 ounces of fecal matter before the defecation reflex is fully initiated. So if you don't even build up that much over the day, you'd have to strain to prime the rectal pump. Hippocrates thought bowel movements should ideally be 2 or 3 times a day, which is what you see in populations on traditional plant-based diets, and the kind of fiber intakes you see in our fellow great apes, and what may be more representative of the type of diets we evolved eating for millions of years. It seems somewhat optimistic, though, to expect the average American to adopt a rural African diet. We can, however, eat more plant-based, and bulk up enough to take the Hippocratic Oath to go 2 to 3 times a day. No need to obsess about it. In fact, there's actually a bowel obsession syndrome, characterized in part by ideational rambling over bowel habits. But 3 times a day makes sense. We have what's called a gastrocolic reflex, which consists of a prompt activation of muscular waves in our colon within 1 to 3 minutes of the ingestion of the first mouthfuls of food. Even just talking about food can cause your brain to increase colon activity. This suggests the body figured that 1 meal should be just enough to fill you up down there, so maybe we should eat enough unprocessed plant foods to get up to 3 a day, a movement for every meal. Compared to rural African populations eating traditional plant-based diets, white South Africans and black and white Americans not only have more than 50 times the heart disease, 10 times more colon cancer, more than 50 times more gallstones and appendicitis, but also more than 25 times the rates of so-called pressure diseases, diverticulitis, hemorrhoids, varicose veins, and hiatal hernia. Bowel movements should be effortless. When they're not, when we have to strain at stool, the pressure may balloon out pouchings from our colon, causing diverticulosis, inflate hemorrhoids around the anus, cause the valves in the veins of our legs to fail, causing varicose veins, and even force part of the stomach up through the diaphragm into our chest cavity, causing a hiatal hernia, as I covered previously. When this was first proposed by Dr. Burkitt, he blamed these conditions on the straining caused by a lack of fiber in the diet, but did acknowledge there were alternative explanations. For example, in rural Africa, they used a traditional squatting position when they defecated, which may have taken off some of the pressure. For hundreds of thousands of years, everyone used the squatting position, which may help by straightening the anorectal angle. There's actually a kink right at the end of the rectum, almost a 90-degree angle that helps keep us from pooping our pants when we're just walking around. But that angle only slightly straightens out in a common sitting posture on the toilet. Maximal straightening out of this angle only occurs in a squatting posture, potentially permitting smoother bowel elimination. I remember sitting in geometry class thinking, when am I ever going to use this? Little did I know one day I'd be calculating anorectal angles with it. Stay in school, kids. So how did they figure this out? They filled latex tubes with radiopaque fluid, stuck them up some volunteers, took x-rays with their hips flexed at various angles, and concluded that flexing the knees towards the chest, like one does squatting, may straighten out that angle and reduce the amount of pressure required to achieve emptying of the rectum. But it wasn't put to the test until 2002, when researchers used defecography, which are x-rays taken while the person is defecating, both in a sitting and squatting position, and indeed, squatting increased the anorectal angle from about 90 degrees all the way up to about 140. So, should we all get one of those little stools for our stools, like the squatty potty that you put in front of your toilet to step on? No, they don't seem to work. The researchers tried adding a footstool to decrease sitting height, but it didn't seem to significantly affect the time it took to empty one's bowels, or significantly decrease the difficulty of defecating. They tried even higher footstools, but people complained of extreme discomfort using them, so nothing seemed to compare with actual squatting, which may give the maximum advantage, but in civilized countries it may not be convenient. But a similar effect can be achieved if you lean forward as you sit with your hands on or near the floor. They advise all sufferers from constipation should adopt this forward-leaning position when defecating, as the weight of your torso presses against the thighs, putting an extra squeeze on your colon. But instead of finding ways to add even more pressure, why not get to the root of the problem? Right? The fundamental cause of straining is the effort required to pass unnaturally firm stools. By manipulating the anorectal angle through squatting or leaning, you can more easily pass unnaturally firm stools, but why not just treat the cause, and eat enough fiber-containing whole plant foods to create stools so large and so soft that you could pass them effortlessly at any angle? Cardiologist Dr. Joel Kahn once said, "You know you're eating a plant-based diet when you take longer to pee than to poo." But seriously, even squatting does not significantly decrease the pressure gradient that may cause hiatal hernia. It does not prevent that pressure transmission down into the legs that may cause varicose veins. And this is not just a cosmetic issue. Protracted straining can cause heart rhythm disturbances, reduction in blood flow to the heart and brain, sometimes resulting in defecation-related fainting and death. 15 seconds of straining can temporarily cut blood flow to the brain by 21%, cut blood flow to the heart nearly in half, thereby providing a mechanism for the well-known bedpan death syndrome. You think you have to strain sitting? Try having a bowel movement on your back. Bearing down for just a few seconds can send your blood pressure up to nearly 170/110, which may help account for the notorious frequency of sudden and unexpected deaths of patients while using bedpans in hospitals. Of course, hopefully, if we eat healthy enough, we won't end up in the hospital to begin with. Though many reported feeling better on Dr. Kempner's rice and fruit diet, he refused to accept that as evidence of success. He wanted objective measurements, the most famous of which were so-called eye grounds photographs, taken with a special camera that allowed one to visualize the back of the eye. And in doing so, he proved that not only could diet arrest the bleeding, oozing, and swelling you can see in the back of the eye of people with severe kidney, hypertensive, or heart disease, but actually reverse it. Something never even thought possible. Here's the before, here's the after. Reversal to such a degree that even patients who could no longer distinguish any objects have been able to read fine print, a reversal of blindness with diet. The results were so dramatic that the head of the Department of Ophthalmology at Duke, where Kempner worked, was questioned as to whether they were somehow faked. He assured them that they were not. In fact, he wrote in one person's chart, "This patient's eye grounds are improved to an unbelievable degree." Not only had he never seen anything like it, he doesn't even remember ever seeing a patient with such advanced disease even being alive 15 months later. The magnitude of the improvements Kempner got were surprising. Reversal of end-stage heart and kidney failure simply beyond belief. But as Kempner said as his closing sentence of a presentation before the American College of Physicians, the important result is not that the change in the course of the disease has been achieved by the rice diet, but that the course of the disease can be changed at all. Now that we have high blood pressure drugs, we see less hypertensive retinopathy, but still a lot of diabetic retinopathy, the leading cause of blindness in American adults. Even with intensive diabetes treatment, at least 3 insulin injections a day with the best modern technology has to offer, like these implantable insulin pumps, the best we can offer is usually just a slowing of the progression of the disease. So we can, in the 21st century, slow down your blindness. But a half a century ago, Kempner proved you could reverse it. Kempner started out using his plant-based ultra-low sodium, fat, cholesterol, protein, rice diet to reverse kidney and heart failure, but assumed it would make diabetes worse. He expected a 90% carbohydrate diet would increase insulin requirements. However, the opposite proved to be true. He just took the next 100 patients with diabetes that walked through his door that went on the rice diet for at least 3 months, and their fasting blood sugars dropped, despite a drop in the amount of insulin they were taking. But this is what blew people away. 44 of the patients had diabetic retinopathy, and in 30% of the cases, their eyes improved. From like this to this. That's not supposed to happen. Diabetic retinopathy is considered a sign of irreversible destruction. What does this mean in real life? Unable to even read headlines, to normal vision. The remarkable success Dr. Kempner had reversing some of the most dreaded complications of diabetes with his rice and fruit diet was not because of weight loss. The improvements occurred even in those patients that did not lose significant weight, so it must have been something specific about the diet. Maybe it was his total elimination of animal protein, total elimination of animal fat, total elimination of cholesterol, or radical reduction in sodium, fat, and protein in general. We don't know. But how do we treat diabetic retinopathy these days? With steroids and other drugs injected straight into your eyeballs. And if that doesn't work, there's pan-retinal laser photocoagulation, in which laser burns are etched over nearly your entire retina. Surgeons literally burn out the back of your eye. Why would they do that? The theory is that by killing off most of the retina, the little pieces you leave behind may get more of the blood flow. When I see this, along with Kempner's work, I can't help but feel like history has been reversed. Like, yeah, can you believe 50 years ago the best we had was this barbaric burn-out-your-socket surgery, but thank goodness we've since learned that through dietary means alone we can reverse the blindness. But instead of learning, medicine seems to have forgotten. Irritable bowel syndrome is a chronic, episodic intestinal disorder characterized by abdominal pain and altered bowel habits, affecting 1 in 7 Americans, though most go undiagnosed. It can have a substantial impact on well-being and health, and doctors underestimate the impact the disease can have, particularly the pain, the discomfort. Using some measures, the health-related quality of life of irritable bowel sufferers can rival those of much more serious disorders, such as diabetes, kidney failure, and inflammatory bowel disease. So the first step towards successful treatment is for doctors to acknowledge the condition and not dismiss the patient as just hysterical or something. Another reason sufferers often don't seek medical care may be the lack of effectiveness of available treatments. There is a huge unmet therapeutic need. Since there's no cure for IBS, treatment is targeted to alleviate the symptoms. The typical antispasmodic drugs can cause side effects such as dry mouth, dizziness, blurred vision, confusion, and fall risk. But there are new drugs on the market now, like lubiprostone, which can cost $2,000 a year, and cause, as side effects, many of the symptoms you're trying to treat. Linaclotide is one of the newest, $3,000 a year, and again can cause the very problems it's designed to help. Antidepressants are commonly given, but may take 4 to 6 weeks to help for Prozac or Celex, up to 12 weeks for Paxil, and have their own array of side effects, including sexual dysfunction caused by these 3 drugs in over 70% of the people who take them. There's got to be a better way. Acupuncture works, but no better than placebo. What's placebo acupuncture? It's where you poke people with a fake needle away from any known acupuncture points, yet that worked just as well as real acupuncture, showing the power of the placebo effect. I've talked about the ethics of so many doctors effectively passing off sugar pills as effective drugs, who argue the ends justify the means. There's actually a way to harness the placebo effect without lying to patients, though. You tell them it's a sugar pill. Patients with irritable bowel syndrome were randomized to either get nothing or a prescription medicine bottle of placebo pills with a label clearly marked placebo pills. Take 2 pills twice a day. I kid you not. And lo and behold, it worked. That's how powerful the placebo effect can be for irritable bowel. They conclude that for some disorders, it may be appropriate for clinicians to recommend that patients try an inexpensive and safe placebo. Indeed, sugar pills probably won't cost $3,000 a year, but is there a safe alternative that actually works? 9 randomized placebo-controlled studies have found peppermint oil to be a safe and effective treatment for irritable bowel syndrome. A few adverse events were reported, but were mild and transient in nature, such as a peppermint taste, peppermint smell, and a cooling sensation around one's bottom. Whereas in some of the head-to-head peppermint versus drug studies, some of the drug side effects were so unbearable they had to drop out of the study. This suggests that it might be a reasonable approach for clinicians to treat IBS patients with peppermint oil as a first-line therapy before trying anything else. Now, the longest trial only lasted 12 weeks, so we don't know about long-term efficacy, though the benefits may last at least a month after stopping, thought perhaps to be due to lasting changes in our gut flora. The studies used peppermint oil capsules so they could match them with placebo pills. What about peppermint tea? It's never been tested, but one might assume it wouldn't be concentrated enough. But a quarter cup of fresh peppermint leaves has as much peppermint oil as some of the capsule doses they used in the studies, which one could easily blend into a smoothie, or with frozen berries to make something like my pink juice recipe. You can grow mint right on your windowsill. We doctors need effective treatments that are cheap, safe, and available. This is particularly relevant now, as newer and more expensive drugs have either failed to work or been withdrawn from the market owing to concerns about serious adverse events. Just like it might be a good idea to only eat foods with ingredients you can pronounce, it may be better to try some mint before novel pharmacological approaches, such as the new dual mu-opioid agonist delta antagonist drug with a name like J&J 27018966. The results of the Chamaco study were published recently, the Center for the Health Assessment of Mothers and Children of Salinas Valley, California, investigating the relationship between the exposure to flame-retardant chemical pollutants in pregnancy and childhood and subsequent neurobehavioral development. Why California? Because California children's exposure to these chemicals are among the highest in the world, considered to be endocrine disruptors and neurotoxins. What did they find? Both prenatal and childhood exposures to these chemicals were associated with poorer attention, fine motor coordination, and cognition, particularly verbal comprehension, by the time they reached school age. This study, the largest to date, contributes to growing evidence suggesting that these PBDE flame-retardant chemicals have adverse impacts on child neurobehavioral development, and the adverse effects may extend into adolescence, again affecting motor function as well as thyroid gland function, something that may extend into adulthood. These chemicals get into the moms, and then get into the amniotic fluid, and then into the breast milk. And the more that's in the milk, the worse may be the infant's mental development. Breast is still best, but how did these women get exposed in the first place? The question is exposure mostly from diet or from dust? Researchers in Boston collected breast milk samples from 46 first-time moms, vacuumed up samples of dust from their homes, and questioned them about their diets. They found that both were likely to blame. Diet-wise, a number of animal products were implicated. That's consistent with what's been found worldwide. For example, in Europe, these flame-retardant chemical pollutants are found mostly in fish, meat, and other animal products. It's similar to what you see with dioxins, fish and other fatty foods, with a plant-based diet offering the lowest exposure. Well, if that's the case, then do vegetarians have lower levels of flame-retardant chemical pollutants circulating in their bloodstreams? Yes. Vegetarians had about 25% lower levels. Poultry appeared to be the worst. USDA researchers compared the levels in different meats, and the highest levels were found in chicken and turkey, with less in pork and even less in beef. California poultry had the highest, consistent with strict furniture flammability codes. But it's not like chickens are pecking at the sofa. chickens and turkeys may be indirectly exposed through the application of sewer sludge to fields where feed crops are raised, contamination of water supplies, the use of flame-retardant materials in poultry housing, or the inadvertent incorporation of fire-retardant material into the bird's bedding or feed ingredients. Now, fish have been shown to have the highest levels overall, but Americans don't eat a lot of fish, and so they don't contribute as much to the total body burden in the United States. Here's the level they found in meat eaters. Here's the amount found in the bloodstream of vegetarians. Just to give you a sense of the contribution of chicken, here's where higher than average poultry eaters ended up compared to lower than average. Where did the vegans end up? Well, we know the intake of many other classes of pollutants is almost exclusively from the ingestion of animal fats in the diet. So what if you take them all out of the diet? Well, it works for dioxins. Vegan dioxin levels appear markedly lower than the general population. But what about for the flame-retardant chemicals? Vegans came out down here, with long-term vegans who've been vegan around 20 years even lower. This tendency for chemical levels to decline the longer one eats plant-based suggests that food of animal origin contributes substantially. But note the levels never got down to zero, right? So diet is not the only source. The USDA researchers note that there are currently no regulatory limits on the amount of flame-retardant chemical contamination in U.S. foods. But look, reducing the levels of unnecessary persistent toxic compounds in our diet is certainly desirable. By our 70s, 1 in 5 of us will suffer from cognitive impairment, and within 5 years, half will progress to dementia, in a progression from cognitive impairment without dementia to dementia and death. The earlier we can slow or stop this process, the better. Although an effective treatment for Alzheimer's disease is unavailable, even interventions just to control risk factors could prevent millions of cases. So an immense effort has been spent on identifying risk factors for Alzheimer's and developing treatments to reduce them. In 1990, a small study of 22 Alzheimer's patients reported that they had high concentrations of something called homocysteine in their blood. The homocysteine story starts back in 1969, when a Harvard pathologist reported 2 cases of children, one dating back to 1933, whose brains had turned to mush. They both suffered from extremely rare genetic mutations that led to abnormally high levels of homocysteine in their bodies. So is it possible, he asked, that homocysteine could cause brain damage even in people without genetic defects? Well, now here we are in the 21st century, and homocysteine is considered a strong independent risk factor for the development of dementia and Alzheimer's disease. Having a blood level over 14 may double our risk. In the Framingham study, they estimated that as many as 1 in 6 Alzheimer's cases may be attributable to this elevated homocysteine in the blood, now thought to play a role in brain damage, cognitive, and memory decline. Our body can detoxify homocysteine, though, using 3 vitamins: folate, vitamin B12, and vitamin B6. So why don't we put them to the test? No matter how many studies find an association between high homocysteine, cognitive decline, dementia, or Alzheimer's disease, a causal role, a cause and effect role, can only be confirmed by interventional studies. Now, initially, the results were disappointing. Vitamin supplementation did not seem to work. But the studies were tracking neuropsychological assessments, which are more subjective, compared to structural neuroimaging, actually seeing what's happening to the brain. And a double-blind, randomized, controlled trial found that homocysteine lowering by B vitamins can slow the rate of accelerated brain atrophy in people with mild cognitive impairment. As we age, our brain slowly atrophies, but the shrinking is much accelerated in patients suffering from Alzheimer's disease. Kind of an intermittent rate of shrinkage is found in people with mild cognitive impairment, but so the thinking is maybe if we could slow down the rate of brain loss, we could slow down this conversion to Alzheimer's disease. So they tried giving people B vitamins for 2 years, and they found it markedly slowed the rate of brain shrinkage. The rate of atrophy in those with high homocysteine levels was cut in half. A simple, safe treatment can slow the accelerated rate of brain loss. A follow-up study went further by demonstrating that B vitamin treatment reduces by as much as 7-fold the brain atrophy in the region specifically vulnerable to Alzheimer's disease, to the disease process. Here's the amount of brain atrophy over 2 years in the placebo group. Here's the amount of loss in the B vitamin group. Less brain loss. Now, the beneficial effect of B vitamins was confined to those with high homocysteine, indicating a relative deficiency in one of those 3 vitamins. So wouldn't it be better to not get deficient in the first place? Most people get enough B12 and B6, but the reason these folks were stuck up at a homocysteine of 11 is that they probably weren't getting enough folate, which is found predominantly in beans and greens. 96% of Americans don't even make the minimum recommended amount of dark green leafy vegetables, the same pitiful number that don't eat the minimum recommendation for beans. In fact, if you put people on a healthy diet, on a plant-based diet, you can drop their homocysteine levels 20% in just 1 week, up from around 11 down to 9. The fact that they showed significant homocysteine lowering without any pills, without supplements, even at 1 week, suggests that multiple mechanisms may have been at work. They suggest it may be because of the fiber. Every gram of daily fiber consumption may increase folate levels in the blood nearly 2%, perhaps by boosting vitamin production in our colon by our friendly gut bacteria. It could also be from the decreased methionine intake. That's where homocysteine comes from. Homocysteine is a breakdown product of methionine, which comes mostly from animal protein. And so if you give someone bacon and eggs for breakfast, then a steak for dinner, you can get these spikes of homocysteine levels in the blood. Thus, decreased methionine intake on a plant-based diet may be another factor contributing to these lower, safer homocysteine levels. The irony, of course, is that those who eat plant-based diets long-term, not just at a health spa for a week, have terrible homocysteine levels. Meat eaters up at 11, but vegetarians and nearly 14 vegans at 16. Why? They're getting more fiber and folate, but they're not getting enough vitamin B12. Most vegans can be classified as being likely to suffer from hyperhomocysteinemia, too much homocysteine in the blood, because most vegans in this study were not supplementing with vitamin B12, or eating vitamin B12 fortified foods, which is critical for anyone eating a plant-based diet. But if you take vegans and give them B12, their homocysteine can drop down below 5. Why not just down to 11? Well, the reason the meat eaters were stuck up at 11 is probably because they weren't getting enough folate. But once vegans got enough B12, they could finally fully exploit the benefits of their plant-based diets and come out with the best levels of all. Diverticula, or outpouchings from our intestine. Doctors like using a tire analogy. High pressures within the gut can force the intestines to balloon out through weak spots in the intestinal wall, like an inner tube poking out through a worn tire tread. This is what they actually look like. These pockets can become inflamed and infected, and to carry the tire analogy further, can blow out, spilling fecal matter into the abdomen or the bladder and lead to death. Symptoms can range from no symptoms at all, to a little cramping and bloating, to incapacitating pain that is a medical emergency. 9 out of 10 people that die from the disease never even knew they had it. But the good news is that there may be a way to prevent the disease. Diverticular disease is the most common intestinal disorder, affecting up to 70% of people by age 60. If it's that common, though, maybe it's just an inevitable consequence of aging? No, it's a new disease. In 1907, 25 cases had been reported in the medical literature, not in 25% of people, but 25 cases, period. and they're kind of hard to miss on autopsy. 100 years ago, in 1916, it didn't even merit mention in medical and surgical textbooks. The mystery wasn't solved until 1971. How did a disease that was almost unknown become the most common affliction of the colon in the Western world within one lifespan? Surgeons Painter and Burkitt suggested diverticulosis was a deficiency disease, a disease caused by a deficiency of fiber. In the late 1800s, roller milling was introduced, further removing fiber from grain, and we started to fill up on fiber-deficient foods like meat and sugar. A few decades of this, and diverticulosis was rampant. This is what they thought was going on. Just as it would be easy to squeeze a lump of butter through a bicycle tube, it's easy to move large, soft, moist intestinal contents through the gut. In contrast, try squeezing through a lump of tar. See, when we eat fiber-deficient diets, our feces can become small and firm, and so our intestines really have to squeeze down hard to move it along. And this buildup of pressure may force out those bulges. And eventually, a low-fiber diet can then sometimes lead to the colon literally rupturing itself. If this theory is true, then populations that eat high-fiber diets would have low rates of diverticulosis, and that's what's been found. More than 50% of African Americans in their 50s were found to have diverticulosis, compared to less than 1% in African Americans eating traditional plant-based diets. And by less than 1%, we're talking 0 out of a series of 2,000 autopsies, 2 out of 4,000 in Uganda. That's like 1,000 times lower prevalence. What then about this newer study, concluding that a low-fiber diet was not associated with diverticulosis? A study out of the University of North Carolina found no association between dietary fiber intake and diverticulosis in comparing the group that ate the highest amount, 25 grams, 3 times the amount of the lowest fiber intake group. They concluded that a low-fiber diet is not associated with diverticulosis. The university sent out a press release: diets high in fibers won't protect against diverticulosis. The press picked it up. Study finds high-fiber diet may not protect against diverticulosis. Went over all the paleo blogs and even medical journals. An important paper calling into question the fiber theory of the development of diverticulosis. Other editorials, though, caught the critical flaw. To understand this, let's turn to another dietary deficiency disease, scurvy. Medical experiments on prisoners in Iowa State Penitentiary showed that clinical signs of scurvy start appearing just 29 days without vitamin C. Experiments on pacifists during World War II showed the same thing, that it takes about 10 milligrams of vitamin C a day to prevent scurvy. So imagine going back in time a few centuries, when they were still trying to figure scurvy out. Dr. James Lind had this radical theory that citrus fruits could cure scurvy. What if an experiment was designed to test this crazy theory, in which sailors were given the juice of either 1 wedge of lemon or 3 wedges of lemons a day? If a month later on the high seas there was no difference in scurvy rates, one might see headlines like this. The printing press pamphleteers would all be touting the study that found that a low vitamin C diet is not associated with scurvy. See, a wedge of lemon only yields about 2 milligrams of vitamin C, and it takes 10 to prevent scurvy. So they would have been comparing 2 milligrams a day to like 3 times that, 7 milligrams. One vitamin C deficiency dose versus another vitamin C deficiency dose. No wonder there would be no difference in scurvy rates. We evolved eating so many plants that we likely averaged around 600 milligrams of vitamin C a day. That's what our bodies are biologically used to getting. What about fiber? How much fiber are we used to getting? over 100 grams a day. The highest fiber intake group in the North Carolina study was only eating 25, which is less than the minimum recommended daily allowance, which is about 32 grams. They didn't even make the minimum. So they compared one fiber-deficient diet to another fiber-deficient diet. No wonder there was no difference in diverticulosis rates. The African populations, where they had essentially no diverticulosis, ate diets consisting part large platefuls of leafy vegetables, similar perhaps to what we were eating a few million years ago. They were eating plant-based diets containing 70 to 90 grams of fiber a day. Most vegetarians don't even eat that many whole plant foods, though some do. At least they hit the minimum mark and had less diverticulosis to show for it. This is a relatively small study, though. 35 years later, 47,000 people were studied, confirming that consuming a vegetarian diet and high intake of dietary fiber both associated with a lower risk of both hospitalization and death from diverticular disease. And they had enough people to tease it out. Compared to those eating a single serving of meat a day or more, those that had less than half a serving appeared to have a 16% lower risk. Pescatarians, no meat except some fish, down 23%, though neither statistically significant. But eating vegetarian was 35% lower risk, and those eating strictly plant-based appeared to be at 78% lower risk. As with all lifestyle interventions, it only works if you do it. High-fiber diets only work if they're actually high-fiber. The endothelium is the inner lining of our blood vessels. Laid end to end, the endothelial cells from a single human would wrap more than 4 times around the world. And it's not just like an inert layer, it's highly metabolically active. I've talked about how sensitive our endothelium is to oxidation and inflammation. If we don't take care of it, endothelial dysfunction may set us up for heart disease or a stroke. Are we ready to heed our endothelium's early warning signal? Well, if it's all about oxidation and inflammation, then fruits and vegetables should help, and indeed they do. Each daily serving of fruits or vegetables was associated with a 6% improvement in endothelial function. Now, these fruit and vegetable-associated improvements in endothelial function are in contrast with several negative vitamin C pill studies that failed to show a benefit. It can be concluded that the positive findings in the fruit and vegetable study is not just because of any one nutrient in fruits and veggies. Rather than searching for the single magic bullet micronutrient, a more practical approach is likely to consider whole foods. Thus, increasing fruit and vegetable consumption is likely to have numerous beneficial effects due to synergistic effects of all the wonderful things in plants. Exercise helps too, but what type of exercise helps best? Patients were randomized into 4 groups: aerobic exercise, cycling for an hour a day; resistance training, using weights and elastic bands; both or neither. The aerobic group kicked butt. The resistance group kicked butt, and the aerobic and resistance group kicked butt as well, compared to those who sat on their butts. Note that your endothelium doesn't care if you're on a bike or lifting weights, as long as you're getting physical activity and getting regular activity. If you stop exercising, your endothelial function plummets. Antioxidant pills didn't work. But what about anti-inflammatory pills? Drug companies aren't going to give up that easy. After all, there's only so much you can make selling salad. For those who prefer plants to pills, one of the most anti-inflammatory foods is the spice turmeric. Researchers in Japan recently compared the endothelial benefits of exercise to that of curcumin, the yellow pigment in turmeric and curry powder. About a teaspoon a day's worth of turmeric for 8 weeks compared to 30 to 60 minutes of aerobic exercise a day. Which group improved their endothelial function more? The group that did neither experienced no benefit, but the exercise group significantly boosted their endothelial function, and so did the curcumin group. The magnitude of the improvement achieved by curcumin treatment was comparable to that obtained with exercise. Therefore, regular ingestion of curcumin could be a preventive measure against cardiovascular disease in postmenopausal women. Furthermore, their results suggested that curcumin may be a potential alternative treatment for patients who are unable to exercise. But ideally, we do both. In this study, they looked at central arterial hemodynamics. Basically, if our endothelium is impaired, our arteries stiffen, making it harder for our heart to pump. But compared to placebo, we can drop that pressure down with turmeric curcumin or exercise. But if you combine both, then you really start rocking and rolling. They conclude that these findings suggest that regular endurance exercise combined with daily curcumin ingestion may reduce the pressure against which your heart has to fight to a greater extent than one or the other. So, healthy eating and exertion for our endothelium. Water is by far the #1 nutrient in our diet. Studies have suggested that proper hydration may lower our risk of heart disease and cancer, and may even make you a better kisser. Brushing artificial skin against the lips of young women, researchers found that hydrated lips showed greater sensitivity to light touch. Although it is well known that water is essential for human survival, only recently have we begun to understand its role in the maintenance of brain function. Makes sense. Our brain is 75% water, and so when we get dehydrated, our brain actually shrinks. Even mild dehydration caused by exercising on a hot day has been shown to change brain function. I've talked about the role of hydration for cognitive function, but current findings suggest that our mood states may also be positively influenced by water consumption. The effects of dehydration in real life have not been well documented. It wasn't until 2013 when the first study to investigate the effects of mild dehydration on a variety of feelings was published. What did they find? The most important effects of fluid deprivation were increased sleepiness and fatigue, lower levels of vigor and alertness, and increased confusion. But as soon as they gave them some water, the deleterious effects on alertness, happiness, and confusion were immediately reversed. Water absorption actually happens very rapidly, within 5 minutes from mouth to bloodstream, peaking around minute 20. And as an aside, the temperature of the water appears to matter. Which do you think is absorbed more rapidly, cold water or warm body temperature water? Cold water gets sucked into the body about 20% faster. How can you tell if you're dehydrated or not? Why don't you ask your body? If you chugged down some water and then turned around and just peed it all right out, presumably that would have been your body's way of saying, I'm good, all topped off. But if you drank a bunch of water and your body kept most of it, then presumably your tank was low. So these researchers formalized the technique. You empty your bladder, and then chug down 11 milliliters per kilogram body weight, or 5 milliliters per pound. There's about 240 milliliters in a cup, so that's about 3 cups of water. You drink 3 cups of water, and then an hour later see how much you pee. The empty circles on this graph up in the corner are the dehydrated folks. So basically this says if you drink 3 cups and pee out less than 1, there's a good chance you were dehydrated. Depression is a serious and common mental disorder responsible for the majority of suicides. But as I already covered, intakes of fruits, vegetables, and naturally occurring antioxidants have been found to be protectively associated with depression. So, they concluded, it may be possible to prevent depression or to lessen its negative effects through dietary intervention. But not so fast. That was a cross-sectional study, meaning a snapshot in time, so you don't know whether the poor dietary pattern precedes the development of depression, or if depression causes poor dietary intake. Depression and even treatments for depression can affect appetite and dietary intake. Maybe people who feel crappier just eat crappier instead of the other way around. What you need is a prospective study, a study performed over time where you start out with people who are not depressed and follow them for 6 years, and those with higher carotenoid levels in their bloodstreams, which is considered a good indicator of fruit and vegetable intake, was associated with a 28% lower risk of becoming depressed within that time. So they conclude that having low blood levels of those healthy phytonutrients may predict the development of new depressive symptoms. But what about suicide? Worldwide, 1 million people kill themselves every year. In this comparison of European countries, Greece had the lowest rates of suicide. Maybe it's the balmy weather, but maybe it has something to do with their diet. 10,000 people followed for years, and those following a more Mediterranean diet pattern were less likely to be diagnosed with depression. What was it about the diet that was protective? It wasn't the red wine or the fish. It was the fruit and nuts, and effectively higher plant-to-animal fat ratio, and beans that appeared protective. Conversely, significant adverse trends were observed for dairy and meat consumption. A similar protective dietary pattern was found in Japan. A high intake of vegetables, fruit, mushrooms, and soy products was associated with a decreased prevalence of depressive symptoms. It was not characterized by a high intake of seafood. 100,000 Japanese men and women were followed for up to 10 years, and they didn't find evidence of a protective role of higher fish consumption or those long-chain omega-3s, EPA and DHA against suicide. In fact, they found a significantly increased risk of suicide among male non-drinkers with high seafood omega-3 intake. This may have just been due to chance, but a similar result was found in the Mediterranean. High baseline fish consumption, together with an increase in consumption, were associated with an increased risk of mental disorders. One possible explanation could be the mercury content of fish. An accumulation of mercury compounds could increase the risk of depression. We know that mercury in fish can cause neurological damage, such as negative effects on Alzheimer's disease, memory loss, autism, as well as depression. So the increased risk of suicide among persons with a high fish intake might be attributable to the harmful effects of mercury in fish. The big Harvard cohorts found similar results. Hundreds of thousands followed for up to 20 years. No evidence taking fish oil or eating fish lowered risk of suicide, with a trend towards even higher suicide mortality. What about for the treatment of depression? Neither EPA or DHA appeared more effective than just sugar pills. And the same can be said when one puts all the trials done to date together. We used to think omega-3 supplementation was useful, but several recent studies have tipped the balance the other way. It seems that nearly all the treatment efficacy observed in the published literature may be attributable to publication bias, meaning the trials that showed no benefit tended not to get published at all, and so all one saw was a bunch of positive studies, but only because a bunch of the negative ones were buried. Previously, I've explored the beneficial effects of flax seeds on prostate cancer, as well as breast cancer prevention and survival, thought to be because of the lignans in flax seeds, which are anti-cancer plant compounds found in red wine, whole grains, greens, cruciferous vegetables, but especially sesame seeds and flax seeds, the most concentrated source on Earth. But this is per unit weight. People eat a lot more grains than seeds. And of the grains people eat, the highest concentration of lignans are found in rye. So can rye intake decrease the risk of breast cancer? Theoretically, yes, but unlike flax seeds, it's never been put to the test. If you measure the level of lignans in the bloodstream of women living in a region where they eat lots of rye, the odds of breast cancer seem to be cut in half for women with the highest levels, but lignans are also found in tea and berries, and so they couldn't be sure where the protection was coming from. So researchers decided to measure alkyl resorcinol metabolites, a class of phytonutrients relatively unique to whole grains. They collected urine from women with breast cancer and women without, and those with breast cancer had significantly lower levels compared to women without breast cancer, be they omnivores or vegetarians. This suggests that women at risk for breast cancer consume significantly lower amounts of whole grains like rye. But if you follow older women in their 50s through 60s, the intake of whole grain products was not associated with risk of breast cancer. A similar result was found for older men. Whole grain consumption in one's 50s and 60s did not seem to be linked to prostate cancer risk. Is it just too late at that point? Well, we know from data on dairy that diet in our early life may be important in the development of prostate cancer, particularly around puberty when the prostate grows and matures. And so if you go back and look what men were drinking in their adolescence, daily milk consumption appeared to triple their risk of advanced prostate cancer later in life. And so researchers looked at daily rye bread consumption during adolescence, and indeed, those who consumed rye bread daily as kids may have cut their odds of advanced prostate cancer in half. This is consistent with immigrant studies suggesting that the first 2 decades of life may be most important for setting the pattern for cancer development in later life. Certainly important for how we should feed our kids, but if we're already middle-aged, is it too late to change course? To answer that question, researchers in Sweden put it to the test. How about we take men who already have prostate cancer, split them up into 2 groups, half get lots of rye bread, the other half get lots of high-fiber but low-lignan wheat bread, and see what happens. There's been some indirect evidence that rye may be active against prostate cancer, like lower cancer rates in regions with high rye consumption, but it has never been directly investigated until this study. Biopsies were taken from their tumors before and after 3 weeks of bread eating, and the number of cancer cells that were dying off were counted. There was no change in cancer cell clearance in the control bread group, but a 180% increase in the number of cancer cells being killed off in the rye group. A follow-up study lasting 6 weeks found a 14% decrease in PSA levels, a cancer marker suggesting a shrinkage of the tumor. Now, they note since they used very high rye bread intakes, it remains to be tested if more normal intake levels would have effects that are of clinical importance. As any good red-blooded American, my ignorance of the metric system did not flag 480 grams of rye bread a day as out of the ordinary, but that translates to 15 slices a day. Rather than eating a loaf of bread a day, the same amount of lignans can be found in a single teaspoon of ground flax seeds. Previously, I profiled a paper that added up all the deaths caused by medical care in this country, the 100,000 deaths from medication side effects, plus all the deaths caused by errors, etc., concluding that the 3rd leading cause of death in America was the American medical system. What was the medical community's reaction to this revelation? After all, it was published in one of the most prestigious medical journals, the Journal of the American Medical Association, by one of our most prestigious physicians, Barbara Starfield, who literally wrote the book on primary care. When she was asked in an interview what the response was, she replied that her primary care work has been widely embraced, but her findings on how harmful and ineffective healthcare could be received almost no attention. Recalling the dark dystopia of George Orwell's 1984, where awkward facts are swallowed up by the memory hole, as if they never existed at all. Report after report has come out, and the response has been a deafening silence both in deed and in word, failing to even openly discuss the problem, leading to thousands of deaths. We can't just keep putting out reports, we have to do something. The first report was in 1978, suggesting about 120,000 preventable hospital deaths. The response? Silence for another 16 years until this scathing reminder was published. If you multiply 120,000 by those 16 years, you get 1.9 million preventable deaths, about which there was near total doctor silence. Silence meaning no substantial effort to reduce the number of those deaths. The Institute of Medicine then released its landmark study in 1999, allowing for another 600,000 deaths to take place. Now, some things have finally changed. Work hour limits were instituted for medical trainees. Interns and residents could no longer be worked more than 80 hours a week, at least on paper, and the shifts couldn't be longer than 30 hours long. Now, it may not sound like a big step, but when I started my internship, I was working 36-hour shifts every 3 days, so that's 117-hour work weeks. What's the big deal? Well, when interns and residents are forced to pull all-nighters, they make 36% more serious medical errors, 5 times more diagnostic errors, and have twice as many attentional failures. That doesn't sound so bad until you realize that means like nodding off during surgery. The patient is supposed to be asleep during surgery, not the surgeon. Impairing performance as much as a blood alcohol level that would have been made it illegal to drive a car, but can still do surgery. So no surprise, 300% more patient deaths. Residents consider themselves lucky if they get through training without killing anyone. Not that the family would ever find out. Doctors, with rare exceptions, are unaccountable for their actions. The Institute of Medicine report did break the silence and prompted widespread promises of change, but what they did not do is act as if they really believed their own findings. For if they really believed that a minimum of 120 people every day were dying preventable deaths in hospitals, you'd draw a line in the sand. Like if an airliner was crashing every day, you'd expect the FAA would step in and do something. The Institute of Medicine could insistently demand that doctors and hospitals immediately adopt at least a minimum set of preventive practices, like, for example, barcoding drugs so there's no mix-ups, like they do for even a pack of Twinkies at the grocery store. Rather than just going on to write another report, they could bluntly warn colleagues that they would publicly censor those who resisted implementing these minimum practices, calling for some kind of stringent sanctions, but instead, we get the silence. Dr. Starfield didn't stay silent, but she is unfortunately no longer with us. Ironically, she may have died from one of the adverse drug reactions she so vociferously warned us about. She was placed on aspirin and a blood thinner, Plavix, to keep a stent she had to have placed in her coronary artery from clogging up. She told her cardiologist she was bruising more, bleeding longer, but that's the risk you hope doesn't outweigh the benefits, until she apparently hit her head while swimming and bled into her brain. Now, the question for me is not whether she should have been on 2 blood thinners for that long or had the stent inserted in the first place, but whether or not she could have avoided the heart disease in the first place, which is 96% avoidable in women. The #1 killer of women need almost never happen.